these are the two aspects of this DO, I thought, that pregnancy and thyroid disorders. Before we say thyroid disorders, let's see, before the disorder starts, what are the effects of a normal pregnancy on the thyroidal axis. And unless we are very well versed with this aspect of the physiology, we are never be able to going to take care of the effects of thyroid illness on the pregnancy and the management of thyroid illnesses during pregnancy. So let's first talk about what are the effects of a normal pregnancy on thyroid physiology. So what are the physiological changes in the thyroid function tests? It may not mean abnormal thyroidal axis. It may just mean changes in the level which may be assay dependent, which may be protein dependent, which may be a normal change during pregnancy because of the change in the physiology. And how the new guidelines are giving us insights about what should be called normal and what shouldn't be called normal. And then we go ahead with diagnosing a problem. Once we know what is normal, then only you can diagnose what is subclinical hypothyroidism during pregnancy, what is overt hypothyroidism during pregnancy, and what is overt hyperthyroidism during pregnancy. So let's look at a case, and that's Mrs. Sunaina, who is a 26-year-old lady, pregnant, came to us on 6th week of gestation. As soon as the pregnancy is diagnosed, a routine thyroid function was done. There was no signs of thyrotoxicosis, but she had severe morning sickness. And this was her thyroid function test. What do you suggest? What is it? What is the report saying? If you did not have the history, what did the report say? Overt hyperthyroidism, because the TSH is low and T4 is high. Is that the diagnosis? Okay, so what's the next step? We put her on anti-thyroid medications. How many for anti-thyroid medications for this lady? No? How many for no anti-thyroid medication for this lady? Okay. Right, okay, free T4 level. Let's see what happens and why we'll not treat this report as considering it as a hyperthyroidism, which is an overt disease. Because if you look at these three things, this is a curry which all hotels make, and they add either chicken, paneer or shave to it to make it 3 different vegetables, which are different but yet similar at their base. Similarly, there is a same alpha glycoprotein base to all the hormones that are TSH, FSH, LH and beta HCG. And when the beta subunit of this hormone is attached, which is slightly different from each other, then different hormones are produced. And that is why during first half of pregnancy, because of increased in the beta HCG, the TSH is fooled and the TSH is lower. Because the beta HCG is high, the TSH is lower. So this is normal beta HCG graph during pregnancy. The graph of TSH is going to be the mirror image of this. So in the first half of pregnancy, because of high beta HCG, TSH is going to be low. The second graph tells us that because there is increase in the protein during pregnancy, which will lead to increased globulin and subsequently thyroid binding globulin. So the total T4 is going to be high, but the free T4 is going to be normal. Now if we overlap these gaps, we do not check TBG and we do not check beta HCG for thyroid evaluation. So these two graphs goes. So what we get is a high total T4 and a low TSH, which is classical example of hyperthyroidism. But this is normal for pregnancy, right? So a low TSH and a high total T4 is absolutely normal physiology during pregnancy and doesn't mean that the lady has hyperthyroidism. So what are the different variations? First, second and third trimester. Now, this is the second part of our normal physiological changes in the pregnancy. And we know for ages, like we were discussing, the guidelines for thyroid disorders have not changed since years together. We always knew that the lower limit of TSH during pregnancy is 0.1 in first trimester, 0.2 in second trimester, 0.3 in third trimester. And the upper limit needs to be below 2.5 in first trimester and below 3 in second and third trimester. This is something which has changed recently. And the 2017 guidelines say that throughout the pregnancy, if TSH is below 4, you don't need to worry. You don't need to treat TSH which is less than 4, whether it is first trimester, second or third. So a low TSH, high total T4 is normal during pregnancy, and we do not need to treat TSH if it is less than 4 for subclinical hypothyroidism. So understand what is not hyperthyroidism during pregnancy and what is not hypothyroidism during pregnancy. So total T4 up to 1.5 times of the higher limits of normal is normal. So if non-pregnancy range upper limit of TSH is 12, T4 is 12, in pregnancy it is 18. And free T4 will remain same. So should we check free T4 and not T4 in all pregnancies? So FT4, which is measured in this country, is by immunoassay, which is not reliable during pregnancy. And T4, the changes are so predictable that we actually do not need free T4 in anybody. You can safely do T4, just remember to change the normal range to the pregnancy levels. So she was not treated for anything, and the thyroid function improved after the first trimester was over. So what can beta-HCG do during pregnancy to the thyroid axis? It can cause transient toxicity. If it is slightly more severe, it can cause hyperemesis gravidarum, and that's not because of thyroid, that's because of high beta-HCG. But it will get reflected as a severe hyperthyroidism. Molar pregnancies and choriocarcinomas are very rare. So coming to the second part, how are we going to deal with when we confirm that this is abnormal for pregnancy? So subclinical hypothyroidism, whom to treat? This is the question in thyroid experts. And here is where TPO antibodies come to us in very handy way. So everybody who has TSH more than 2.5, it is expected to do TPO antibody. And if it is positive, we can definitely treat if TSH is more than 4. You can consider treating if it is between 2.4 to 4. Less than 2.4, do nothing. If thyroid antibodies are negative, even during pregnancy, you can wait up till TSH of 10. And this is the new guideline. So, in nutshell, if TPO antibodies is positive, you can treat, I would say safely, if TSH is more than 2.5. Up to 4, more than 4, definitely. But why take chances? I would not like to take chances. If TPO antibody is positive, TSH more than 2.5, I will treat. If TPO antibody is negative, we can wait till TSH of 10, even during pregnancy. So overt hypothyroidism in pregnancy treatment, I don't think there is anything new. Just that the target has not changed. Even though the diagnostic threshold is changed to 4, the treatment target has remained to 2.5. This is something which I wanted to highlight. The next case, 28 years, first pregnancy, 8 weeks of gestation, diagnosed to have thyrotoxicosis during evaluation of weight loss and anxiety during first trimester of pregnancy. Very strangely, generally you do not come across this situation, but the husband said that the lady is generally a very cool person, which we are not. As a ladies, we are not cool, but she was cool, and she suddenly became anxious during first trimester of pregnancy, and they came to us. So that suggests that she has severe symptoms of thyrotoxicosis during pregnancy. Proptosis was present. And how we can guess proptosis? Because that is something which will not happen during short exposure of thyrotoxicosis. So I find it very useful to ask the lady to show me her old photograph and then compare it with the current photograph to see whether really proptosis is present or not. So this was her thyroid function. T4 is 24, 23, and TSH is not detectable. So the diagnosis is Graves' disease in this case. So how are we going to differentiate between HCG-mediated thyrotoxicosis and Graves' disease? I am not able to see the timer. Can you tell me the time, please? Yeah. 11 minutes left? Okay. So how do we differentiate between Graves' disease and HCG-mediated hyperthyroidism? So HCG-mediated hypothyroidism is very common. This is not hyperthyroidism per se, but the report showing hyperthyroidism, right? So this is very common, up to 1 to 3% of pregnancies, which is huge in India, right? And Graves' disease is very rare. And Graves' disease getting diagnosed first time during pregnancy is even rarer. So do not think of Graves' disease at first thing when you are dealing with a lady with hyperthyroid report. The changes in TFT because of beta-HCG are not very severe. That will be very severe in Graves. T4 may be more, T4 is generally more than 25, 30, 40, even more than that. Symptoms may or may not present. Symptoms may be present in HCG-related thyrotoxicosis. One, because the TSH level is going to be low. Second, because pregnancy itself is a stage of hyperdynamic circulation, which can mimic thyrotoxicosis. Graves' disease, severe symptoms will be present, especially if the symptoms related to orbitopathy, that is eye disease, and something like pretibial myxedema. If you find these changes, then they are very specific for Graves. No kind of beta-HCG related hyperthyroidism can cause orbitopathy and pretibial myxedema. So if these things are present, be sure it's Graves' disease. HCG-mediated hyperthyroidism is definitely going to improve in the second half of pregnancy. Graves' disease will not. It might become more difficult to treat hyperthyroidism in later parts of pregnancy. The pointers to beta-HCG-mediated hyperthyroidism are: 1, severe morning sickness, very common in twin pregnancies because the level of beta-HCG is going to be very high. And Graves' disease, orbitopathy, and positive TRABs. This is something, probably pregnancy is the only clinical condition. Forget about the research. Pregnancy is probably the only clinical condition where we do advise thyroid receptor antibodies to differentiate between Graves' disease and HCG-mediated hyperthyroidism if clinical symptoms are not enough to do that. There is no role of doing nuclear scan during pregnancy. We cannot do. So how do we treat Graves' disease during pregnancy? We have 3 options, as you know: antithyroid, radioiodine, surgery. Radioiodine is cut during pregnancy. We cannot do it. In second trimester of pregnancy, we can do surgery, but that's a very, very rare case which is going to be. Antithyroid medications are the mainstay. Now, antithyroid medications, skin rash, liver dysfunction, agranulocytosis, these are the common side effects irrespective of pregnancy. What we are worried here are potential teratogenic effect. And this is a real serious problem because both thionamide as well as PTU have teratogenic side effects. The concept that we have that PTU is safe during pregnancy is no more valid. PTU is also equally teratogenic, just that the teratogenic effects of PTU are less severe than thionamide. So it is the choice is to have either aplasia cutis or face and neck cyst and urinary tract abnormality. That is the choice we have because both the drugs are potentially teratogenic. Now, let's see what is the time period which we can save if we want to have or if we want to minimize the teratogenic effects of these drugs on pregnancy and the fetus. Now, you have no idea what happens during first 5 weeks because you diagnose pregnancy only at that time. After 5 weeks till 10 weeks is the maximum teratogenic period. If you can avoid exposure of antithyroid drugs between 5 to 10 weeks, you have done with the pregnancy antithyroid management. So what is suggested is that if somebody is already on medication and becomes pregnant, you stop antithyroid medication for 5 weeks. Try to somehow manage the lady symptomatically up to 10 weeks of pregnancy and then restart antithyroid medication. There we have to guess whether thyrotoxicosis is more detrimental or the antithyroid medications are more detrimental to the child and to the lady. So this is a very crucial part. PTO is still preferred in first trimester of pregnancy. So what do we do with this lady who presented with Graves' disease during 6th week of gestation? We started her on PTU. We told her this is not the safe drug, but because she was severely thyrotoxicosis, we had to start her on drugs. We could have waited till 10 weeks. There is no strict guideline, but you have to take that judgment on case basis. Then if you can look at this real record of that lady of my EMR, liver function and hemograms, I I prefer to do it in pregnancy to see if something is going wrong or not. Signs of thyrotoxicosis which were present are reduced during the next visit. As first trimester is completed, then she was shifted from PTU to carbimazole. And this was her follow-up TFT. What I want you to notice here is that the T3 and T4 have come down quite well. The T4 13 would be normal for pregnancy. I would not want it to be below 12. TSH will take a long time to normalize. So do not look at TSH when you are trying to treat hyperthyroidism. It may take months together to become normal, up to 6 months I have seen. T3, T4 becoming towards the lower side of the normal is good enough. Do not over-treat hyperthyroidism during pregnancy. Slight hyperthyroidism during pregnancy is absolutely okay. So coming back to the summary of the talk, we still have 4 minutes. Coming back to the summary of the talk, 1, understand that there are real changes happening in the thyroidal axis and the thyroid hormone tests, laboratory tests, because of pregnancy. The physiological changes in thyroidal axis will make us believe that beta HCG related changes are hyperthyroidism, which they are not. The normal ranges of TFT are different in pregnancy. The guidelines have changed. The threshold for diagnosing subclinical hypothyroidism has gone up. Slightly over-treat hypothyroidism if you are in dilemma during pregnancy, and slightly under-treat hyperthyroidism if you are in dilemma during pregnancy. So with that, I would end the presentation, and 3 minutes we have.